Hey everyone, this is our session on healthcare. I'm Stephen Foll, and I'm a research scientist at Google, and I'll be moderating the session today. We have five really exciting talks. One of them will be remote. We'll be going through sequentially. Each presenter will have 10 minutes. I'll hold up a sign with a 2-minute warning, and then as you're getting to 0 minutes, I'll hold it up again and just try to finish. And then at the end, we'll have a Q&A session with everyone jointly. If you have questions at the end, feel free to come up and line up at the mic at the end or add your questions to the Hopin platform. So with that, I'll hand it over to John Rudnick from the University of Michigan.
Before we get started, I just wanted to highlight ongoing negotiations between the University of Michigan and the Graduate Employees Organization there. The university has engaged in a variety of hostile behaviors deleterious to graduate students' health and well-being. One way to show your support and solidarity with workers is to donate to our strike fund by visiting givebutter.com/GEO strike fund. So, how do people moralize their work? This question is important as a relatively nascent stream of research seeks to understand how ethics are operationalized. To start to answer this question, our work draws on contributions from sociology. Specifically, we draw on morals and market scholarship, which blurs the boundaries between economic and social domains to provide an account of how people ascribe cultural, moral, and financial worth to people, activities, qualities, and objects. Characterized by an overlap between difficult working conditions and emotional attachment, care work stands out as a paradigmatic case for understanding the relationship between morality and technology development and design. Over the past half-century, the most appropriate way of caring for older adults has been a topic of ongoing debate amongst policymakers, academics, and interest groups in the US and globally. Further, the overwhelming majority of care is provided by women and people of color. This work is often invisible, accorded little value, and only sometimes recognized as skilled labor. Together, these characteristics of care work stand in stark opposition to engineering work, which is generally well compensated and performed predominantly by men. Our empirical work entailed a case study of a staffing platform for non-medical home care for older adults. Platforms for home care have emerged to meet the growing demand for care for older adults in the United States as the population ages. And such care does not usually involve skilled labor or skilled nursing services, but yet provide support for older adults' physical, social, and emotional needs as they continue to age in their home. It is against this backdrop that we sought to understand how these actors moralize their work and the problems that the workers encounter. Our study begins with these two research questions. How do technologists build algorithms in this context, and what are the impacts of these technologists' decisions? The subject of our case study, CareTech, is one of several startups that are credited with reinventing the home care agency model. Prior to data collection, CareTech acquired Stay Home, a traditional home care staffing franchise. CareTech partners with traditional home care agencies to support back-end administrative, legal, compliance, and logistics functions while using an algorithm to evaluate caregivers and match caregivers to care recipients. When we started data collection, CareTech's technology platform had recently been implemented at Stay Home's company-owned agencies, providing a unique opportunity to investigate algorithm implementation. A stream of research in the field of AI ethics has focused on how ethics are operationalized in practice, focusing primarily on the organizational and cultural factors that inform actors' actions, behaviors, and outlooks. We contributed to this line of work by drawing on the work of French sociologist Luc Boltanski and French economist Laurent Thévenot, who theorized how people draw on multiple principles of evaluation to make decision and orient action. We mobilized this idea of moral frameworks as we focus on the patterns of action, symbolic investment, and critical capacities that participants drew on in discussing their interaction with the platform. The study draws on data gathered from 1 week of observation performed in July 2022 and 30 interviews conducted between May 2022 and August 2022, which we coded abductively. We sampled participants using purposive and convenience sampling to understand the perspectives of 3 different types of actors: technologists, caregivers, and coordinators. We found that technologists drew on multiple moral frameworks to navigate contextual complexity. They discussed competing goals, demands, and expectations, and discussed how the platform as a solution to problems in the home care industry. When specifically asked about the development and use of staffing algorithms, technologists described datafication and the use of algorithms as oriented towards maximizing the strength and longevity of the relationship between caregivers and care recipients. However, algorithms and metrics were often undergirded by concerns about operational efficiency, obfuscating caregivers' insights into their own performance. Further discussions with dissatisfied caregivers and coordinators revealed how asymmetries in platform design increased the difficulties that caregivers and coordinators faced in their care practices. We emphasize that our research extends efforts to investigate ethics in technology organizations as an ongoing practice. By investigating the moral dimensions of technology design and interaction, we highlight how longstanding problems are defined and suitable solutions are presented. In our case, the datafication of care and the use of staffing algorithms presents new challenges for caregivers and is incongruent with coordinators' evaluations. We highlight the use of moral frameworks and the flexibility of moral concepts, or the moral polysemy of care, to demonstrate one explanation for how and why technologists seek to displace previous practices with algorithmic tools. Second, we highlight how algorithms are ambiguous artifacts, moralized in ways that competed with their functional purposes, demonstrating new opportunities for investigating how algorithm design is entangled with specific practices, ideologies, and contexts. Third, we show how moralization impedes technologists' insight into the consequences and practices of their research, and how hierarchies of interpretation emerge, potentially exacerbating existing inequalities. And as I close, I'll generalize the implications of our research. We highlight how tensions in moralization have negative consequences for caregivers, as some populations have less to gain from technologists' moralized drive towards efficiency. In addition, we introduce morality as an analytic to extend analyses of how ethical AI is accomplished. Just to close, I wanted to break the findings down by the different sorts of roles that people occupied in the organization. And we interviewed technologists to uncover how they drew on multiple moral frameworks to justify their work across these contexts, using care flexibly to moralize their practices. And while caregivers and coordinators were mostly happy with the conditions that they faced on the platform, they discussed sort of the boundary between work and personal life breaking down, as well as needing to make changes to the way that they spent their time on the job. And finally, while coordinators sympathized with staffing difficulties, but they did not find a lot of utility in the survey-based evaluations, all of which you can read more about in our paper.
Now welcome Ji-Young Kim from Duke University.
Good afternoon, everyone. My name is Ji-Young Kim. I'm a qualitative research scientist at Duke Institute for Health Innovation and also a project member team of Health AI Partnership. So today, I'll be talking to you about some of the work that we've done on organizational governance of AI adoption in healthcare. So healthcare is both highly regulated and rapidly evolving in the United States. However, not all medications, tests, and devices are strictly regulated by the FDA. So to fill the gap of limited scope of FDA regulations, health systems have ensured safety, efficacy, and equity of new innovations through governance processes developed by various verticals of healthcare technology. So when it comes to AI, however, despite its growing use in healthcare, there is currently no clear and established governance ecosystem. So to address this issue and promote safe, effective, and equitable use of AI, we initiated the current project. Our initial goals were to define usable resources to support health system leaders and examine the current state of practical institutional adoption of AI technology within health systems in the US. So first, we launched Health AI Partnership by recruiting 11 health system health organizations and 2 ecosystem partners. Then we collaborated with IDEO.org for a 6-week design sprint to design products and programs that health systems leaders find immediately useful in practice. So we recruited health system leaders, representatives from the partner sites, and external AI ethics experts to have them participate in a series of usability testing sessions. From the usability testing sessions, we were able to create a simple design prototype for a guideline for AI adoption. And then the prototype was structured around mock key decision points that align with how health organizational leaders approach technology adoption. The mock key decision point served as a scaffolding for our team to build upon with more rigorous and comprehensive qualitative research. Concurrent with the design research, we conducted qualitative research using in-depth interviews to understand the current and aspirational state of AI adoption in healthcare organizations. We recruited 89 professionals in healthcare and other relevant fields. And for interviews, we created an interview guideline and asked participants questions about processes and personals involved across 4 distinct stages of AI adoption. All interviews were then transcribed and organized through 2 cycles of coding. Then after the second cycle of coding, we mapped the most prevalent themes and sub-themes onto the framework that we developed from the design research. So we found that the major themes were grouped into 8 key decision points across the entire process of AI adoption. And within each key decision point, we identified processes and practices, as well as challenges and risks that health system leaders experience when they adopt AI in their setting. So for the interest of time, I'll quickly go through 8 key decision points and provide some brief descriptions for each. And if you're interested in learning more about best common practices that we surface from each decision point, please check out our full manuscript. So the first stage of AI adoption, which is problem identification and procurement, involved 2 key decision points. The first key decision point described how organizations identify a high priority problem and consider adopting AI product to solve the problem. The second decision point described how organizations conduct an initial evaluation to examine whether the adoption of the AI product is feasible. The second stage of AI adoption, which is development and adaptation, involves 3 key decision points. The third decision point described how organizations set their goals and define measurable outcomes along technical and socio-technical dimensions. The fourth decision point described how organizations develop workflows and user experience surrounding AI product to facilitate its adoption into clinical care. And the fifth decision point described how organizations conduct a comprehensive review of data and evaluate the AI product to validate that technology meets user and organization requirements. The third stage of AI adoption, which is clinical integration, involved 1 decision point that described how organizations provide necessary communication, education, and support to frontline workers to adopt the solution and ensure success to achieve desired outcomes. The last phase of AI adoption, which is post-integration lifecycle management, involved 2 key decision points. So 1 decision point described how organizations monitor the technical, operational, and organizational aspects of the AI product and work environment to ensure that they continue to function appropriately. And then the last decision point described how organizations may make improvements to the AI product or work environment, or they decide to terminate use of the AI product. So while there is no explicitly shared and comprehensive set of best practices of AI adoption in healthcare, our interview surfaced a set of common practices that health systems already engage in. So our interviews found that health systems understand an AI product as part of a socio-technical system that involves the humans, the policy environment, and the practical considerations of clinical care. And they try to work with interdisciplinary teams of clinicians, technical experts, and data scientists. Health systems also develop documentation and explanatory artifacts of the AI product and data to foster calibrated clinician trust while respecting their agency and expertise. We also found that health systems understand that AI governance requires new resources and expertise beyond current capabilities of health systems. Health systems are in need of shared standards to governing the AI adoption process. The absence of shared framework creates social and economic costs on individual health systems, impedes AI adoption, and undermines safety, efficacy, and equity. We believe that our key decision points shared among many health systems can serve as an initial use for developing shared standards for AI adoption. In fact, to further share our knowledge and empower a community of healthcare professionals, we created a website, healthaipartnership.org. We hope that our multi-organizational effort can help health systems make informed decisions around adopting emerging technology. So on that note, I would like to thank our funder and everybody who's been part of the project. Thank you everyone for listening.
So next we'll have a online presentation from Lawrence Munch, I believe. You got it. Okay. Oh, I thought you had the video. No. Okay. I can try to pull it from the online if you have it. I believe that's just a PowerPoint. We can maybe pull it from the website, but why don't we jump to the fourth talk and figure it out? We'll jump back. All right, let's actually jump ahead to our fourth talk from Melissa McCradden, the Hospital for Sick Children.
Okay. Wait, it's a PDF.
Yeah.
Whoops. What did I do? Sorry. Oh, I think you gotta go back.
Yeah, let's just go.
No worries. Okay, perfect. All right, thank you. Hi, I'm Melissa. I'm a clinical ethicist, a researcher, and the director of AI integration at the Hospital for Sick Children. And I'm really excited to talk to you about our institutional framework for addressing fairness and justice-related concerns across the AI lifecycle. So I think we're all here because we know what algorithmic bias is. We define it here as the potential to either directly or indirectly disadvantage a group by virtue of their identity. Abiba Barani calls these algorithmic injustices, and we consider them an ethical threat to the ethical testing and clinical use of machine learning tools in healthcare systems. So we developed the JustFab guideline, which is justice, equity, fairness, and anti-bias, across a number of years based on a number of consults that came to me and to other groups at the hospital. The goal is that this guideline can help us identify, analyze, and address algorithmic bias. We draw a lot from many of our predecessors, such as the Algorithmic Bias Playbook and the NIST standards, but we explicitly define JustFab as a resource that focuses on impact to individuals rather than centering notions of technical performance. By doing so, we prioritize medical ethics principles and social justice commitments across the life cycle. We also look to try and make this generalizable across contexts by remaining inclusive to non-Western ethical frameworks, which is a noted limitation of previous work. So JustFab is guided by something called standpoint epistemology. This is a feminist theory that advocates that the quality of science improves with multiple standpoints. So it's not just about being nice people and including lots of people in the discussion. It fundamentally leads to a better scientific product at the end. It reflects different ways of knowing, so lived experience as one way of knowing, community knowledge, knowledge passed from elders. These are also valuable insights in terms of making science better. And so it considers knowledge as a social product. And in this case, the knowledge that we aim to generate through JustFab is knowledge about what should be done regarding issues of algorithmic bias. And we consider this the necessary ethical foundation for making decisions to implement ML tools that will aid in improving justice and health equity. So this started as an organizational policy, but people expressed a lot of interest in our work going along, so we started looking to whether this might be helpful to other folks as well. We've been really grateful to work with colleagues across the UK, across the continent of Africa, in the US, as well as Australia. The overall process is mapped onto our clinical integration policy at SickKids, which has a four-stage process, starting with the development and in silico testing of a model, followed by prospective non-interventional testing, i.e. silent trials. Following that, we have prospective testing through different modalities in clinical research, all the way from observational testing to randomized clinical trials, followed by a monitoring protocol. As I said, this was sort of developed iteratively through a number of consultations and then more formatively tested through 4 use cases before proceeding to looking to its generalizability. We have a number of equity-deserving groups at SickKids. We're really fortunate to have a robust EDI department. So we went to all of these groups at multiple points throughout this testing, and it continues to be an ongoing forum for feedback. So I actually go back to these groups routinely to talk about what we're learning, new problems that may have come up, to continue to have their insights. So it starts with this first stage, which is divided into 2 substages, which will look quite familiar to anybody who works in algorithmic bias. The first step is looking at the preparation and conceptualization, starting with a literature review and potential consultation. So at this stage, based on the literature, based on known health equities, we would be looking to a priori identify potential groups that might be at risk based on the use case that you're looking at in developing a particular model. So again, many of us are probably familiar with Ziad Obermeyer's work regarding problem formulation. This is a key point where we find that consultation is really helpful because various groups can help us define the problem in a way that really centers the impact to patients. When we look to data inclusivity, we need to know what our inputs are and understanding the context. So for instance, if we're looking at a precision medicine-based paradigm and we have information such as gender, which might be binary coded based on the annotation on the health card, that might not be the best way of getting information relating to perhaps how different individuals respond pharmacokinetically to different drugs. And so we have to think about what the specific inputs are in relation to the use case that we're talking about, and then look to the representation within the data set that we have access to. Dataset reflexivity is another really great exercise that we've really found helps our teams enrich their understanding of the data. This is through things like data sets for data sheets or health sheets for data sets. And really helping people work with the people who are actually entering the data. So we found a number of cases where problems for algorithms have been identified because they spoke to the unit clerks who are actually entering the data into the systems. This allows us to develop an analytic plan. So there have been some pitfalls in terms of the literature wherein apparent group differences might be related to the actual distribution of features within each subgroup. And so it's important to have an analytic plan that allows you to isolate those features, whether by controlling for confounders or covariates. At this stage, we're ready to conduct algorithmic validation, so looking at the fairness distribution of the model by testing and comparing performance across the different subgroups that we had identified a priori. This is where many people will kind of explore different algorithmic fairness methods for testing potential differences within the data. We sort of remain agnostic to the reliability or the suitability of any of these methods, really having this be a decision that's been driven by the machine learning experts. But overall, the idea is that whatever you're using, you need to test it, and I'll get to that in the second stage. We also say it's important at this point to test for post-hoc grouping. So work going on in looking at hidden stratification, which was something that was advanced by Dr. Lauren Oakton-Rainer, has revealed that there might be clinically significant differences in performance that you might not be able to test for a priori. And so looking for those potential hidden stratification effects is another important control for fairness. So at this stage, what we should have is essentially an empirical foundation for ethical decision making. So learning all that we can about how our candidate algorithm is performing, we can select a fairness strategy to guide implementation. So identifying the potential biases that will pose challenges to the equitable impact of these models, we engage in a process called reflective equilibrium. This is something that's done in ethics analysis, whereby we reflect on different values, different potential options, and identify their ethical strengths and vulnerabilities. So in doing so, we can look at our different values. One of those values might be predictive accuracy, so the most important thing to prioritize might be the accuracy of a model, potentially still including the fact that there might be biases inherent within those models' predictions. Another possibility is that we implement a model that is operationalizing a form of formal justice, i.e. treating everyone the same or equality. Whether you do that through different problem formulation, increasing representation within your data, or imposing constraints on the model or its outputs. And then finally, a third possibility of a prioritized value is distributive justice, whereby we might look at who is the most disadvantaged in this circumstance and look to specifically advance their needs over the needs of others. Once we've selected this value, we have to test it. So silent phase testing is a way to actually test whether our assumptions will hold up on the ground. For the sake of time, I'm not going to get into a huge amount of detail, but this is where human factors becomes really important, because we can test what the implementation plan can be, how it will affect the workflow, how it influences hidden labor of people who work with the system. We can also embed considerations about respect for persons and ethical use. So how you actually phrase the outputs of your model. Are you calling people normal or abnormal? Are you saying genetic abnormality? These are really important things where, again, consultation can play a role. At the third stage, once we have a model that we think is ready for clinical testing through a modality of testing paradigms, we want to think about diversity, so making sure that we are enabling people all with the opportunity to participate in research, perhaps through translating different protocols, translating informed consent materials, having notices and things like that. Thinking really carefully about the ethical justifiability of consent paradigms, whether they're relatable to the people who are most disadvantaged by our health systems. And then considering the comparison to the status quo. Dr. Obermeyer gave a great example where the status quo might be deeply biased and an algorithmic means might be better. And so thinking about what you're comparing your algorithm to is really important to determining whether or not you can influence health equity. And then finally, of course, we need to monitor for safety on a prospective basis. So overall, we advocate for informed choices with respect to model design and validation, prioritizing the empirical demonstration of model performance based on on-the-ground evidence. How these outcomes should be influenced is subject to collaborative decision-making, which should be guided by those who have the most at risk from these systems, and ongoing performance must be monitored for safety. And we always kind of make the point that health equity can't be achieved with ML alone, but it can be a tool toward nudging our health systems toward a more equitable delivery of care. This is the really incredible group of people who have worked on this with me. I'm really, really grateful to their help, as well as to the following groups at SickKids, who we continue to have ongoing collaboration and consultation to keep benefiting from their collective insights. So thank you so much.
All right, I'm now going to try to get the online presentation to work.
Hello.
Actually, we're good.
Hello. My name is Lauritz, and I'm zooming in from beautifully sunny Aarhus in Denmark today to give you a brief overview over our FACT 2023 paper called 2 Reasons for Subjecting Medical AI Systems to Lower Standards than Humans. This is a paper I've written with 2 co-authors. And over the next roughly 10 minutes, I'm going to give you an overview of the main context and arguments of this paper. I pasted my email address at the bottom of this slide, so feel free to get in contact if you find any of this stuff interesting. Okay, so the background for this paper is really the so-called double standards debate about algorithmic decision making that we find in the current literature. And this debate is really concerned with the question of, well, suppose that you have a reasonably well-functioning decision system based on human decision makers. So that could be in a medical context where you rely on medical doctors for diagnosing or treating patients. The question is really here, well, when you think about replacing these doctors with an AI system supposed to solve the same decision problem, as it were, what kind of standards should we hold these AI systems to in order for us to know that we are justified in relying on them? So here we just understand standards as normative requirements that must be met for permissible use. And in the double standards debate, we see that people take quite different views on what we should think of the relative standards for AI systems and humans. So some say that AI systems, for instance, in the context of transparency, must be equally transparent to humans in order for us to permissibly rely upon them, whereas others say they must be more transparent. So here's an observation that really frames the entirety of our paper. This debate about double standards as it has been conducted so far has mostly been concerned with the value of opacity. So for instance, Cirilli and co-authors has a 2019 paper where it is argued that we shouldn't require that AIs or AI systems are more transparent than humans in order for us to permissibly rely upon them. And furthermore, they say that we tend to overestimate how transparent humans really are. And in the same context, Kassir Sadeh and Günther argue that we should, in fact, sometimes hold AIs to higher standards. We should demand more transparency of AI systems than we should demand of a human decision maker for making the same or solving the same decision problem. So the first contribution in our paper is really predominantly a methodological point. So even though the question of double standards could be seen as really broad, it has mostly been asked and discussed in the context of transparency, or the value of transparency, as we saw on the former slide. However, we could, in principle, raise, and perhaps we should raise, a similarly structured question for just about each value we hope decision-making to promote. So we could ask, for instance, for accuracy, or for fairness, or for equity, whether we should hold AI systems to higher or lower or the same standards as we hold human decision makers when they seek to address the same decision problem. So that's really the first point we're making in this paper. Perhaps we should broaden the scope of the double standards debate. And then the second point in the paper is more substantive, and we explore the case for double standards in the context of decisional accuracy specifically. or for the value of accuracy. And we do so in a medical context. And we find the surprising conclusion that we are sometimes justified in holding AI systems to lower standards than humans in order for us to permissibly rely upon them, which is quite an interesting and surprising finding. So first, to get to touch some common ground, what do we mean by accuracy? And here we mean something quite simple and straightforward. So let's compare a human doctor and a medical AI system that are both tasked with diagnosing a patient or a group of patients based on an input vector of symptoms. And here we just understand the overall accuracy of the relative systems, or the different systems, as the amount of true predictions they make divided by all the predictions they make. So accuracy is the fraction of all the predictions that hits the mark, as it were. So on this way of understanding accuracy, the question really turns into whether we ever accepted in using AI systems that performs more poorly than human decision makers in terms of accuracy. And we present two reasons for why this might occasionally be the case. So the first reason has to do with cost effectiveness, and the second reason has to do with speed. So the first reason, cost effectiveness. There is some evidence already suggesting that there will be AI systems that are less costly to implement and maintain than comparable human decision-making systems. So we cite some evidence from a study on diabetic screenings in Singapore. But even though the judge is still out on the precise cost and benefit structure of AI systems, we can still make the assumption that, or the speculation that some AI systems will possibly be more cost-effective than human decision or human-based decision systems. And the important point really here is that, well, if some medical AI system is much more cost-effective compared to a comparable human decision-making system, well, then all else being equal, then we can actually justify relying on this AI system, even though it performs worse in terms of accuracy than the human system. And why? Well, the thought behind this claim is rather simple. And it's perhaps easiest to see in the context of medical decision-making. If we accept a more cost-effective decision system, it means that we'll save quite a number of resources, and we would be able to redirect these resources to other areas, potentially resulting in more health for the same amount of money. So that would be one reason why we would sometimes have a reason to accept AI systems that are less accurate than human decision systems. A reason that flows from specific facts about the cost structure of having algorithmic decision systems. Of course, it's through and through an empirical question when these conditions obtain, but insofar as we can imagine that they will sometimes obtain, we have an argument for why we could be justified in accepting that our AI system is less accurate than a human decision system. So here's the second reason. Oftentimes, AI systems, medical AI systems, are much faster at arriving at their predictions compared to humans. And while speed need not always be that important, or at least the speed differential between humans and AI, it can occasionally be, specifically in cases where the opportunity costs of slow decision-making are very severe and the consequences of unnecessary treatment are acceptable. And we illustrate this in the paper by focusing on the case of sepsis. So sepsis is interesting because treating sepsis is very, very time sensitive. So in a paper, it is suggested that for every hour treatment is delayed of sepsis, there is a risk of death, increased risk of death by roughly 8%. And that is quite a lot. But if that's the case, that we have a decision problem where speed is very important, and occasionally AI systems can be more speedy than human decision systems, then we have a very strong reason to prefer AI systems, even though they are less accurate. So what's the underlying rationale here? Well, the rationale is that if the human decision system is sufficiently slow, then even though it will get some or more predictions correct than the AI system, the time sensitivity of the subject matter will imply that more people could actually end up dying simply because they are diagnosed and treated too late. Again, bear in mind that every hour of treatment delay for sepsis increases the risk of death by roughly 8%. So that could actually mean that we would sometimes be justified in accepting a less accurate system, provided it's much quicker in diagnosing people. And this is really what is illustrated in this figure. At time 3, we have death caused by sepsis, and at time 2, we have the time at which the human diagnosis is in. At time 1, we have the time at which the AI diagnosis is in, assuming here that sometimes the AI system could actually be faster. And there's actually some evidence showing this as well. Okay, so these were the two core arguments of the paper. And the upshots are really, well, first the methodological point that we raised, that the double standards debate, as it has so far been conducted, should perhaps be broadened to focus on other values than transparency only. And then we argue, and that is perhaps a surprising conclusion, that in the context of predictive accuracy, we might in fact sometimes be justified in relying on AI systems that are less accurate than human decision systems, suggesting that we are justified in holding AI systems to lower standards than humans. And this is quite a novel finding, because most papers focusing on this question, the double standards debate, has either argued that we should hold AI systems to the same standards, or that we should expect more, demand more of AI systems than we demand of human decision makers. Thank you for your attention.
Okay, we'll go ahead and move on to our final speaker. It's Raphael Poulain from the University of Delaware. Thanks.
So hello everyone. So my name is Raphael Poulain. I'm a PhD student at the University of Delaware, and today I will be talking about our paper, Improving Fairness in AI Models on Electronic Health Records, the case for federated learning methods. So first, let me dive in a little bit into the motivations for this work. So federated learning can help increase the diversity of the dataset, and would thus allow for fairer predictive models in healthcare predictive tasks. So basically, federated learning would allow multiple clients to collaboratively train a single model without sharing their data, which is key, especially in high-stake applications like healthcare, where data privacy is quite a big concern. Additionally, fairness in healthcare is usually only considered for binary sensitive attributes, like think about gender, for example. However, attributes like race, insurance type, or age are by nature non-binary and have been shown to be also great source of biases, specifically in the healthcare domain. And lastly, federated learning methods that investigate fairness usually rely solely on the weight allocation process, leaving the local debiasing part to the discretion of each client, and sometimes also unknown to the reader of each studies. So how can we actually apply federated learning for healthcare applications, like machine learning healthcare applications? So as I said, federated learning would allow for multiple healthcare sites, could be either a hospital or a government entity, to collaboratively train a single model without sharing the actual data sets. And usually a federated learning round, what we call a round, could be dissected into three distinct steps. First one being where each client would train a model on their own local data sets. Then the client would send the trained parameters model to a server, an aggregator, and then lastly, the aggregator would aggregate those parameters and send them back to the client. That would represent one round of federated learning, and it would usually be repeated numerous times until convergence. So now how did we actually quantify fairness throughout this paper? So even though there are many, many different metrics, here we chose to focus on two different kind of metrics, namely the parity-based metrics and the minimax metrics. So for the parity-based, we have defined the true positive rate parity standard deviation, which basically calculates how much from the true positive rate differ from one subpopulation to the other, with the goal obviously being the true positive rate being fairly similar from one group to the other. So here it's a minimization process. Similarly, we have the accuracy parity standard deviation, which is fairly similar. The only difference being that it's not the true positive rate, but the accuracy. And lastly, we have the worst true positive rate, worst TPR, where here instead of focusing on how much each subpopulation diverge in their metrics, we are trying to optimize for the worst performing group. And by optimizing for the worst performing group, the goal would be ultimately to optimize for an entire group iteratively. So our proposed method tackles fairness on two different levels. First, at a client level and a server level. For the client level, we perform local debiasing through adversarial removal of sensitive information, which I'm going to get to in a second. And on the server level, we have proposed a fair aggregation process that allocates more weight to consistently fairer clients. And also, I would like to mention that our proposed method is agnostic to the fairness metric. So even though throughout the paper we have only optimized our model for the three metrics that I've previously discussed, it could theoretically be applied and optimized for any metrics of your choosing, even not fairness related. So for the local debiasing, so first, for the backbone of our actual model, we have chosen to go for a quite popular architecture in the healthcare world, which is a bidirectional RNN, so a recurrent neural network with an attention mechanism. And on top of that, we have added a classifier that will be trained to predict the sensitive attribute of each patient given the representation produced by the RNN. And alternatively, simultaneously, we have the rest of the model that is trained to produce representations that do not contain sensitive information while remaining useful in the downstream task. So that is where the adversarial part comes in, where we have one classifier that will be trained to classify each patient to their respective sensitive attribute, while the rest of the model is trying to make it impossible, so therefore not contain any sensitive information in the latent spaces. And obviously, while still remaining decently accurate in the predictions. And for the server side, we have a fair aggregation process, and we have based our algorithm on the popular Fed average algorithm that basically assigns a weight to each client that is proportional to the size of their respective data sets, and then when they aggregate the parameters, like respectively to those weights. But here we do something a little bit different. The way we calculate the weights for each client, on the first round is basically the weights for Fed average, but then on subsequent rounds, the new client's weight depend on the previous weights and their current fairness metric. And by doing so, this allows us to reward consistently fair client. And the rationale behind this is that we want to reward clients that have produced fair prediction for numerous rounds in a row, rather than having it being disregarded by a client that oscillates between very fair and very biased prediction. And on top of that, we also have a little hyperparameter beta that balances out how much attention, how much weight we give to the fairness budget. If beta here would be equal to 0, then our proposed method would basically be the same as Fed average with no fairness constraints whatsoever. And the higher value of beta, the higher value we give to the fairness budget. And I will also show later on that too high of a value for beta actually becomes counterproductive. So for the experiments, we have chosen 2 data sets, and for each of those data sets, we have divided into 2 different cohorts, so 2 cohorts for each data set. The first data set being the Synthia data set, which is a synthetic electronic health record. And on this data set, we have performed a mortality prediction task after inpatient visit discharge. And we have two different scenarios, the first one being the most populous US states. And here, you can see the different statistics for each data set. So the most populous state is just the 5 most populous US states. And the heterogeneous states is more hand-picked state that shows very different data distribution. So here we have Maine and Mississippi, because Maine is the US state that has the higher, in terms of percentage, the highest white population, while Mississippi has the highest black population. So that's how we simulate a scenario where the data sets are fairly different. And on the MIMIC3 dataset, we have a mortality prediction in the ICU task, and we have 2 different cohorts, the MIMIC3 IID, where each patients were randomly assigned to a client, and the MIMIC3 non-IID, where we have fairly different data distribution from one client to the other. And for the results, there are mainly 2 takeaways that we can draw from those results. The first one is we have basically compared our methods to 3 different baselines, the first one being no-fade. No-fade means all the clients have trained their models locally on their own dataset and report the dataset of their own local model, so no faded learning involved at all. Then we have fair average, which, as mentioned, involves fair learning, but without any fairness concerns. Fair-fade is a competitive method that also try to tackle fairness for fair learning methods, and then we have our proposed methods. And as we can see, for the difference between no-fade and fair average showcases already just the impact that federated learning can have on healthcare deep learning methods. So just by increasing the biodiversity of the data, it's already pretty good to showcase better fairness results. And also our proposed method have achieved better or competitive results to fair-fade, showing that our methods achieve state-of-the-art results in terms of fairness while remaining on par on accuracy with fair average, because there will always be somewhat of a trade-off between accuracy and fairness. And lastly, I want also to discuss about the impact of the fairness budget. So that's the hyperparameter beta that I was mentioning earlier. So as we can see, as we increase beta linearly, the accuracy just decreases as beta increases. So that's for the top left figure, which was somewhat expected. Like the more weight you give to the fairness, the less weight you obviously give to the accuracy. But what was more interesting to us is after a certain threshold for beta, the actual results, even for the fairness, seem to decrease. Even though you give more weight to the fairness budget, it does still seem to decrease. And for those data sets, that seem to happen at around 2.5. And the way we explain this because if you give too much of a value for beta, then the optimization process becomes very unstable, and the weight you give to each client starts to go really high and then really low. So that makes the process very unstable and very not smooth at all. So to conclude, I would say that the proposed method allows for healthcare sites to collaboratively train a model that mitigates fairness for scenarios where the sensitive attribute is non-binary, which is critical. And on top of that, also the method is by nature agnostic to the desired fairness metric, which is also something that we deemed as very critical. And lastly, the proposed method not only mitigates fairness as part of the aggregation process, but we've also showed that just having a federated learning-based algorithm implicitly helps with addressing data imbalance by just increasing the dataset size and therefore showcasing better fairness results. So thank you very much for your attention. I would also like to thank my co-author, Farhan, and my advisor, Professor Beheshti.
Let's thank all our speakers again for the amazing talks. So let's go ahead and have our speakers come up and take a seat in the front. We have about maybe about 6 minutes for questions. If anyone has a question, feel free to walk up to the mic. Oh yeah, if there's someone in the audience who has a question, feel free to come up, and otherwise we can take questions from Hopin. Yeah, go ahead. If you have a question, you can just use that mic. Yeah.
So hi, I did not understand your name very clearly, but okay. So thanks for the paper. It's kind of refreshing to have this type of very analytical papers with arguments as we like them in analytic philosophy, namely very clear, rigorous, and leading to counterintuitive conclusions. So yes, it was really cool. But still, I have two questions. One is whether you've considered whether there is a lower boundary to accuracy that is owed to people. So some sort of non-comparative standard below which the machine prediction should not go, and whether this standard can also be different for machines and for AI and humans. Otherwise, the argument seems to be incomplete. But maybe you have that in part 2 of the paper. And the second question is, to what extent do you believe that the argument generalizes to a different context, or whether it is extremely context-specific? Thank you.
So our speaker, laureates, who I think that'd be most relevant to, isn't available today to respond. But is there anyone on the panel who has something, I guess, to contribute in the sense that their work intersects? Melissa, perhaps, thinking about sort of standards of evaluation, particularly when it comes to equity and so on.
Yes, I think one of the questions that came up for me was whether these two functionalities are in fact comparable tasks in that the analogy is appropriate. And I'm not entirely sure as to what subset of medical decisions that would apply to, since even if you look at the task of diagnosis, in many cases, it's not as simple as, a yes or no. I'm also compelled by the evidence that AI systems make mistakes that humans don't make. And so I think that, like many papers have shown, something that is clearly advantageous is the use of each complementarily. So using them together, thinking about what combination can actually work the best. So, and I think that there are going to be situations where you need that expert knowledge to appropriately interpret the outputs of AI systems, such that I don't think that you would be able to say that these two tasks are equivalent.
Thank you. We can take a question from Hupin. So there's a question about the role of informed consent. And, I'll interpret it in the sense of reflecting on your work. How do you feel about how do you think about the role of informed consent in your work broadly? And has this changed at all in the setting where you're thinking about data sources that are crawled from larger contexts beyond perhaps maybe your health system, where you may be able to obtain informed consent? And then has this also changed at all kind of in thinking about modern machine learning approaches with foundation models, et cetera? So let's see. Anyone immediately want to respond? Sure.
Yeah, this is something that I deal with all the time. I sit on the research ethics board for our hospital, so I'm one of the people who kind of makes the decision if you can have a waiver of consent or implied consent or not. And it's interesting because actually in our clinical integration framework, this question came up of, do you require informed consent, first of all, for silent phase testing, but also for prospective testing? And so keeping in mind the lessons from the Belmont Report and the Nuremberg Code, there is a clear distinction between when you are using something that you are not certain whether it will improve, do nothing, or be worse than the standard of care. There is a clear line where informed consent is needed in order to conduct that. That being said, and being inclusive of other hospital institutions who might employ like a learning health systems framework, they have allowed for waivers of consent under conditions of low risk. And so for our framework, in trying to be inclusive of the many different modalities, we sort of erred on the side of, listen, think really carefully about this, because there are a lot of communities whereby the waiver of informed consent was exactly why they became distrustful of health systems in the first place. And so particularly when we're talking about fairness, I think that's a really important lesson to bear in mind. Some people try and address that with, bringing the community into making some of these decisions, with helping, means of communicating these kinds of things with people who are most affected by them. So I think it is something that is quite complicated, but there is a clear historical precedent here.
Yeah, I work with older adults, and these are populations that are perhaps, maybe it's a stereotype, but they're not well equipped to be informed about precisely what's going on. And there's a question additionally with people who are experiencing many of the cognitive changes that accompany aging, especially in a healthcare context. Do they remember that they provided consent? Are they able to understand what's going on? Is that decision being delegated to a third party? So there's an interesting relational element to that as well.
Okay, let's take just one more question.
Hi, I have a question on the paper related to organizational governance, your paper. So thanks a lot for the paper. It's very related to my PhD research, so I'm definitely going to be citing it a lot. So in particular, I'm interested in your point you made about the FDA and how they don't have a wide reach in terms of regulating these medical devices. Maybe your paper goes into it in more detail, but I was curious the extent to which, you've focused on the practices that have been emerging for like sort of self-governance within the hospitals, but is there a movement that you see within FDA to maybe have a wider reach in regulating these applications, or through your findings, do you sort of see that as an important aspect as well? Not sure if you've covered that though.
We spoke, so for ecosystem partners, we recruited regulators to provide some more insights, but there are still like gray areas definitely, especially when like the definitions of medical devices are not clear. Mark, do you want to comment more on this?
I would say there's much more detail in the paper about what we mean by ecosystem when we talk about governance, because I would say organizational governance is actually not an emergent thing in healthcare. And one of the things that we explicitly do in the paper is we trace the history through one example. So we kind of trace the history of antimicrobial stewardship and how there are explicit structures today that require hospitals to run antimicrobial stewardship programs to retain their accreditation to actually receive federal payments for healthcare. So there's actually many different examples where centralized regulatory actions like an approval for a drug is actually just one component of that innovation diffusing. And then you actually need to build these organizational capabilities and structures, and a lot of the responsibility falls to them to actually manage the use of that innovation in practice. So it's like central regulation is necessary but not sufficient.
Thank you.
And then we also, so we spend, more time mapping out the antimicrobial stewardship case study, but then we also allude to sort of some of these emerging like health technology governance standards. So like one example we trace very briefly in a paragraph or two is like laboratory tests. Like they're not all fully covered by the FDA, especially if they're developed in-house, but whether it was like in-house developed or not, like it still needs to be reimbursed by like CMS, but CMS has certain standards. They're not FDA standards, but they lay out some certain stuff. And like the College of Pathologists, thank you, and the CDC, they articulate sort of guidance for how you can meet these sort of standards. So it's this ecosystem of all these different actors coming together, not just the FDA sort of setting some stuff out. And so that was some of the inspiration for what we were looking at, like of how some of these governance structures can emerge.
Great, thank you.
Just thank all the speakers and thank the audience for the great questions. That concludes our session. Thanks for coming.